Good morning, everyone. Today I'll be presenting 6 cases of intracranial and spinal epidermoid cysts received at Shanti Pathology Lab over a period of 4 to 5 months. Case 1 is a 54-year-old man who presented with giddiness and headache and an episode of seizure. His MRI revealed extraaxial well-defined irregular area of altered signal intensity measuring 2.5 into 3.5 into 3.1 centimeters in the right frontal region in the parafalcine location. The T1 weighted images, this lesion appeared iso to hypointense with few peripheral areas of hyperintensity and heterogeneously hyperintense on T2 weighted and flare images. Patchy areas of diffusion restriction and no evidence of blooming on GRE was noted. On post contrast, the T1 weighted images revealed minimal patchy central and peripheral post contrast enhancement. Case 2 is a 48-year-old lady who complained of headache. Her MRI revealed heterogeneous soft tissue mass lesion which measured 5 into 4.5 into 4 centimeters in the left CP angle cistern. The lesion was predominantly hypointense on T1 and hyperintense on T2 weighted and flare images. Case 4 is a 32-year-old man presented with bilateral lower limb weakness and tingling numbness. His MRI revealed altered signal intensity intramedullary lesion, which measured 1.7 into 2.2 into 6.5 centimeters, involving the conus medullaris and adjacent dorsal cord from D12 to upper one-third of L2 vertebral level. The T1 and T2 weighted images revealed heterogeneous hyperintensity suppressing on T1-FS and showing heterogeneous post-contrast enhancement with areas appearing T1 hyperintense and T2 hyperintense, not suppressing on T1-FS. The lesion was causing focal expansion of spinal cord with scalloping on the posterior cortex of L1 vertebral body. Now, these last 3 cases which we have seen were operated by Dr. Aib Cherian from Karad. Now, this case is a intradiploic extradural retrocerebellar epidermoid cyst. This is a 24-year-old man who presented with headache and giddiness. His MRI revealed small to moderate sized, well-defined mixed intensity, predominantly hypointense on T2. It's an extra-axial SOL noted adjacent to the CP angle cistern on the left side. The lesion measured 2.6 into 2.4 into 2.2 centimeters and revealed predominantly iso to hypointense signal signal intensity on T1 weighted images and no obvious enhancement on post-contrast study with extensive areas of hemorrhagic changes. Now, this patient was operated by Dr. Ravindra Patil from Meerut. Now, the case 5 is a 30-year-old lady who presented with backache. Her MRI revealed a well-defined focal nodular intradural extramedullary lesion in the dorsal spine at D6 level, which showed intermediate signal intensity on T2 weighted images, and this was causing mild compression on the adjacent dorsal cord. This patient was operated by Dr. Prasanna Patankar from Karad. Now, case 6 is a 62-year-old man who presented with headache. On examination, right jaw weakness and temporalis muscle weakness was revealed. The MRI revealed a well-defined extraaxial lesion over right medial temporal region extending over right CP angle abutting the cellar region and intracranial portion of right optic nerve compressing the medial temporal lobes and basilar pons. This lesion measured 38 into 22 into 22 mm. It was T1 hypointense with intense restriction on diffusion weighted image sequences and no obvious blooming on GRE sequences. The T2 hyperintense signal intensity with flare heterogeneous subtle hyperintensities. No obvious enhancement on contrast administration was. This case was operated by Dr. S. Prabhakar and Dr. Nikhil Tadwalkar from Solapur. We received these tumors. They had the very typical appearance of epidermoid cyst on gross examination itself. They had these tumors had thin capsule and the typical pearly white appearance. Now these tumors may be smooth, lobulated or nodular. The internal cystic component may show creamy or waxy areas, and these are made up of desquamated epithelial keratin. The histology is very typical. The cyst wall shows is lined by keratinized stratified squamous epithelium. No skin adnexa or hair follicles are present. The subepithelial tissue is fibrocollagenous and the lumen contains abundant keratin flakes. When these epidermoid cysts rupture, they may lead to foreign body giant cell reaction and abscess formation. The differential diagnosis for epidermoid cyst could be middle ear cholesteatoma in case of congenital lesions. A dermoid cyst. Now, dermoid cyst can be very easily differentiated on histopathology because they will have both epidermal and the skin appendages such as hair follicles, sebaceous cyst, adipose tissue. The mature teratoma will have all the three components. The cystic or that is the adamantinomatous craniopharyngiomas may look on histology, but you have to you will obviously see the peripheral palisading of the basal layers in the stratified squamous epithelium. The wet keratin, host cells, stellate reticulum is present, and presence of cholesterol crystals and keratin component makes craniopharyngiomas very distinguished from the epidermoid cyst. Coming to discussion, the intracranial epidermoid cysts account for 1% of all the intracranial tumors. Although predominantly congenital, epidermoid cysts are usually very slow growing lesions and they present between 20 to 40 years of age. Now, these result from inclusion of ectodermal elements during neural tube closure and typically present in the middle age due to mass effect on the adjacent structures. An uncommon association exists with anorectal anomalies such as sacral anomalies and presacral mass known as Currarino triad. The spinal epidermoid cysts account for 0.5 to 1% in adults. However, they may account for up to 10% of intraspinal tumors in children. Just like the intracranial epidermoid cysts, the spinal ones also result from anomalous implantation of the ectodermal cells during closure of the neural tube between third to fifth week of embryonic life, and these also present at the age between 20 to 40 years. Males are more commonly affected than females. Acquired spinal epidermoid cysts are late complication of lumbar puncture resulting from implanted epidermal elements into the spinal canal. The time interval between lumbar puncture and diagnosis of this epidermoid cyst may vary from a period of 1 year to 20 years. Localization of intracranial epidermoid cysts could be intradural, which account for 90%, and extradural, accounting for 10% of tumors. Now, intradural, the most common location is the cerebellopontine angle, almost 40 to 50%, followed by suprasellar cistern and fourth ventricle. Amongst the extradural location, the most common site is within the skull. Spinal epidermoid cysts are usually extramedullary in location. However, they may be intramedullary on rare occasions. Congenital epidermoid cysts usually occur in the thoracic spine, particularly the congenital intramedullary form and the chordae equina. Acquired cysts are found in lower lumbar region. Spinal epidermoid cysts may be associated with spinal malformations and such as spina bifida and hemivertebrae. Imaging findings on CT scan, these are typical well-circumscribed hypodense masses with minimal to no enhancement. Calcification is rarely found. Potential osseous changes include an expanded spinal canal, laminar thinning, and vertebral body scalloping. On MRI, these are well-defined lesions. Generally, no perilesional edema is noted. Although variable, typical signal characteristics include T1 show typical hypointensity, T2 are hyperintense, on flare, hyperintense as when compared to CSF, and the signal intensity may be homogeneous or heterogeneous depending on the uh, content such as lipid content and protein composition of the cyst. Differential diagnosis of intracranial epidermoid cyst on imaging could be arachnoid cyst, dermoid cyst, inflammatory cyst, cystic tumors such as schwannoma or craniopharyngiomas, and neuroenteric cysts. Differential diagnosis for spinal epidermoid cyst could be again same spinal arachnoid cyst, the dermoid cyst, and neuroenteric cyst. Treatment and prognosis. Surgery is the treatment of choice. Complete resection is usually possible and is curative. However, incomplete resection due to vital structures such as cranial nerves and blood vessels or tightly adherent cyst wall to the cord parenchyma may lead to a risk of recurrence. Thank you very much. If you like the cases I am presenting, do subscribe my channel and share my cases with your colleagues and friends. Thank you so much.